This is the kind of catheter that came into being, that there was a tube over which there was a material wrapped which could be inflated when contrast was injected in that. So either it used to be single lumen, that the same lumen at the top was connected and it inflated with the contrast. So then you cannot really do anything else. The whatever contrast you will put will go in opening the balloon. So this is single lumen kind of balloons which were made. It goes in over a wire, but whatever contrast you put, you cannot take a run. It will just open the balloon, and once you remove the contrast, it will deflate the balloon. When you developed double lumen catheters, then you had a separate lumen for the wire and a separate lumen for the contrast filling the balloon. So the wire lumen you can actually take a run also. So we will talk about double lumen catheters, but this is a single lumen catheter. The wire also goes through this only, and then the problem was that whatever contrast or anything you injected was going to open up this balloon, and it cannot really go into the artery. So then finally they made a double lumen balloon where you can connect two things, one through which the wire can go and the other through which the contrast goes in the balloon. So this is how it used to slowly it started becoming bigger, become profiles becoming smaller, balloon lengths becoming bigger, different combinations were used, and slowly you got these kind of different balloons that were being made. So, what are the parts of a balloon? Basically, you have the balloon length. This is the place where this balloon is present. Total length is different. Main balloon length is between the two markers. It is at this position that the documented size and pressure works. So if you are trying to inflate a 10 mm lesion, this length is what is 10 mm should be there for the balloon. So if they say balloon is 10 mm, it will be between these markers. There will be some additional part, but that is unable to open fully because it is connected to the shaft. So the main thing is called the shaft over which the balloon is attached. The actual part which fully inflates is the balloon length, but there might be a bit of shoulder at each side. The total length to which it dilates is the balloon diameter, balloon length. Then you have this shaft. This shaft will have a length as to till where it can reach. So if you're going to the femoral artery, you want to reach to a certain place, the shaft length should be sufficient for the balloon to reach that location. So this is an important number that you should be clear about, at what length I require, so that you order a correct length of balloon, correct diameter of the balloon, correct balloon length, correct shaft length. So shaft length is for taking the catheter to the right location. Balloon length is what you need to keep in mind is the length of the stenosis, because you would like to cover that in a single balloon as much as possible. Now, when the balloon is deflated, that time the diameter that is there is called the profile, because it is through a sheath you are going to go in. So what diameter sheath you should have so that the balloon can be introduced. Say you have a 5 French sheath, but the balloon profile is similar to 6 French, 7 French, so that balloon will not go through that sheath. So you should know what is the profile of the balloon so that you can actually use the right vascular access in the beginning. And shaft size is the diameter of the shaft. Usually the shaft diameter is smaller, and profile they are almost similar in the new balloon, maybe small difference, but once you have inflated a balloon once and it is being reused, it is then that this profile may be little different from the shaft size. It becomes considerably different. The once the balloon has inflated to its original, the actual size, company new balloon will be very tight. But once it's opened and you've deflated and you've tried to reuse it, at that time the profile might become little bigger. So if that initial tape, box said that it can go through a 6 French sheath, when we use a reusable balloon, we try to take a one sheath higher because it becomes difficult for the reused balloon to go into that sheath. So then you have two ports at the end with two hubs. and one is the one in which you can inject contrast or liquid to inflate the balloon. So this is connected to the balloon and it will inflate and deflate the balloon. Whereas the second lumen is the port through which we do put the guide wire. Also, if we are at a particular location and we want to inject contrast and see, we can put a wire, remove the wire and take a run as well. So this double lumen balloon is what we currently use. Of course, single lumen was just to show how we used stuff, but nowadays most of the balloons in PAD are double lumen balloon, one for the wire and one for the inflation. So these are the things that you should know. Mostly, this is a cone angle, which is the angle between the shoulder and the length of the balloon. And the bigger is this taper, the faster is the taper. It reduces the risk of edge dissection. The longer is this slope, the chances that there will be some forces at this edge which can dissect the artery is higher. So you want it to be as steep as possible. You want this one to be as steep as possible so that there are no differential forces on the arterial wall. So this is the way you will see a balloon outside. This is the profile of the catheter, and when the balloon is deflated, the profile of the balloon. These are two radio opaque markers showing the length of the balloon, and this is an over the wire tip design, so the wire can go inside and the entire thing, the wire comes out from the other end. The better the balloon, it will have reduced shaft profile. Hydrophilic coating will allow it to be smooth and go through good platinum iridium marker bands, reduced crossing profile, improved shoulder, as I told you, and all these things are the uh, in the making of a good or a ideal balloon. So these are the newer developments that led to the kind of balloons that we see today. After that, there are certain properties of a balloon which you should be aware of and you should think about while you are choosing a balloon for your particular case. So crossability is basically dependent on the profile of the balloon. So what happens is the lesion entry profile is the initial point of contact between the balloon and the stenosis. So basically, when you have a stenosed segment, it can be very difficult for the uh, balloon to go through. It is very important that the balloon in its uninflated stage is as thin as possible so that over the wire it can cross the lesion. So that is called the lesion entry. So this is where it will enter. So the balloon actually starts from here and this is the actual place from where it will take its full diameter. So here also this is the crossing profile when the actual balloon starts. This is the lesion entry profile for the catheter. So these profiles, the thinner they are, the smoother they are, the better will be the crossability of the lumen. Next profile is the shaft profile. So finally, sometimes this shaft may be smaller than the balloon if the balloon is a low diameter balloon, and sometimes it may be lesser than the balloon if the balloon itself is a bigger diameter. Usually in the beginning, it's not very uh, different. In the beginning, it is not very different, but reusability, I told you, it can become difficult. So the crossing profile, the shaft profile, and the lesion entry profile, all of these together will kind of decide whether you can cross the lesion easily or not. And as I told you, the bigger difference in an old and new balloon is this crossing profile. This changes once you have used the balloon once, and even if you deflate and repack it, it will never become same as a new balloon. So that is crossability, to cross that lesion over a wire. Now the second part is I've reached that place, I have a thin balloon, but is it what force I am applying? Is it going across through the entire shaft and being applied at the stenotic area? So I'm putting some force Instead of buckling, the entire force should get transmitted to the balloon tip. So how that can be designed? So if you have the shaft column, the main shaft, it should have good strength. If you have a very flimsy shaft, instead of transmitting the forces, it will get buckled itself. So the shaft column strength should be good, so that whatever you pushed from the outside, you are outside the patient, you have to push it, the catheter from there. So whatever you are doing, it should get transmitted to the top in a more uniform manner. Second is kink resistance. So you don't want the catheter to get kinked at any place. So you are going through some turn. Instead, you're putting some force to push it forward. It should not become kinked at the turns. So the thing that you use should be kink resistant. It should be like, maybe say you a rope which can open up properly, rather than a wire which you turn once, it may stay in that direction and form a kink. So you don't want a steel kind of kinking wire. You want something which is very kink resistant, like a rope. The third thing is the wire compatibility. There are two types of balloon. One in which the balloon goes completely over a wire. They are called over the wire balloons. And second is a monorail balloon. We will show you. In that, what happens? Only the tip of the initial 20-30 centimeters of the balloon shaft is where the wire is. It allows you to easily, rapidly exchange the balloons. I will show you further. But in that case, we will come later, that the pushability of the balloon goes down. So remember that for over the wire balloons, pushability is better. And for monorail balloons, the pushability is slightly less. Third is trackability, and the trackability is that it can easily go and take the shapes that you are putting. So over the wire, you are trying to put a balloon, it should be able to track over the balloon. So it depends on two, three things. One is the friction between the vessel and the catheter, the friction between the catheter and the wire over which it is going. So that should be as low as possible. There should be hydrophilic coating which allows it to smoothly pass over each other. A big catheter will find it difficult to track over the wire. A smaller profile catheter will go easily. If you have good flexibility, it will nicely go wherever the wire is going, because we know wire is very flexible. Wire can go anywhere. But a catheter should be able to take those turns as well. For that, the material should be flexible. Finally, inflation and deflation. When you inflate the balloon, it will go to its nominal diameter, and then once you've done the job, you will deflate the balloon and it will reduce in size. So that should be quick, and you should be able to restore and stop flow as good as possible. Of course, the time for is how much it will take to deflate inflate will depend on the balloon volume. What does the volume depend on? One is the diameter of the balloon and the length of the balloon. So bigger the balloon volume, the longer will be the inflation deflation times. The greater the pressure that you place, the greater will be the time it takes to deflate from that pressure. And the cross sectional functional area. So the bigger the area, the faster it will inflate or deflate, because it's sucking out from the back end. So the bigger the area, the entire thing force of the suction will go into the balloon. Now, dilating force, the outward force exerted against a luminal stenosis will depend on the balloon diameter. Of course, a 3 mm will put less balloon, a less force, a 4 mm balloon will put more, 5 more, 6 more, 7 more. So, diameter is one thing. Balloon inflation pressure. So, if you inflate a balloon at 4 mm or 6 mm or 8 mm or 10 mm Hg, of course, the pressure that it applies keeps on increasing. Then, compliance of the balloon material, it is inversely proportional to the force. If the I told you in the beginning also, if the material is compliant, it will not be able to exert force on the arterial wall. And then you have the balloon length. The longer the balloon length, the force gets divided over the entire thing. It will be lesser. The degree of stenosis, higher the degree of stenosis, higher will be the pressure that will be applied on the stenosis, and we will see why subsequently. Some the terminologies that you should be aware of are nominal pressure, rated burst pressure, and mean burst pressure. Now, nominal pressure is the pressure at which the balloon will reach its diameter to which it is supposed to reach. So if the balloon is supposed to reach 6 mm diameter, then the nominal pressure is say 8 mm Hg. Then if you will put 8 mm Hg on the inflation device, it will reach its predefined 6 mm size. But if you keep putting more inflation, slowly the size or the pressure will not increase that much, but there is a chance that the balloon may rupture. So the pressure up to which 99.9% of the balloons will not burst is mentioned at the rated burst pressure. We can usually go up to this pressure if we are trying to open a tough lesion and we feel that it is safe to go up to this pressure. Whereas mean burst pressure, which is sometimes mentioned on some balloons, is not such a good uh, pressure that is mentioned, but it really doesn't give us anything. We will not wait to go to a pressure where 50% of the balloon will burst. But sometimes that is mentioned, and you should not get confused that this is the rated burst pressure up to which we can go. We have to only go till the RBP and not the MBP.